fructose metabolism. Fructose is converted to fructose 1-phosphate by fructokinase. If fructokinase is deficient, then it is called essential fructosuria. Essential fructosuria. What is essential fructosuria? Essential fructosuria, fructose will not be converted to fructose 1-phosphate. Fructose will increase in blood but will be filtered by glomeruli. When it would be filtered by glomeruli, then fructose will be filtered by glomeruli, then it would not be reabsorbed properly, because I told you renal threshold of fructose is low. Yes, that's why. Yes, fructose will be excreted in urine. When it will be excreted in urine, there would be no increased fructose. So you have seen that the disorder is fructosuria, and in this galactokinase, the disorder is galactosemia. Why it is semia and that is fructosuria? The semia is there because galactose is having high reabsorption renal threshold. That's why it is galactosemia, and this is fructose urea. Okay, so essential fructose urea. Okay, fructokinase, essential fructose urea. Yes, means fructose will not increase in blood because all this fructose will be excreted in urine, and that's the reason that patient is asymptomatic. Patient is asymptomatic, and we say yes, it is essential that fructose should come in urine to make the patient asymptomatic. If you want that patient should be asymptomatic, this fructose should be excreted in urine. That's why we say it is essential fructosuria. Why it is called essential fructosuria? Means it is essential to excrete fructose in urine. Yes, this is to keep the patient asymptomatic. Yes, aldolase B deficiency. Aldolase B deficiency, that is hereditary fructose intolerance. Hereditary fructose intolerance, aldolase B is deficient. Okay, when aldolase B is deficient, then fructose 1-phosphate will accumulate. Yes, fructose 1-phosphate again in liver. All the phosphate will be accumulated in the form of fructose 1-phosphate. All the phosphate accumulate in the form of fructose 1-phosphate. So this will not be cut. Glycogen phosphorylase will not be able to cut, because all the phosphate is present in the form of fructose 1-phosphate, and there would be fasting hypoglycemia. There would be hepatomegaly. There would be fasting hypoglycemia, hepatomegaly. There would be, yes, Benedict test positive. So can you tell me how you can differentiate hereditary fructose intolerance and classical galactosemia? Yes, it is increase in blood, increase in blood, fructose increases in blood. It is filtered. Yes, it is filtered. It is filtered freely. When it is filtered freely, it is filtered freely, it is reabsorbed, but not renal threshold is low. That's why, yes, that's why renal threshold is low. I told you that glucose and galactose are reabsorbed mostly, but fructose are not reabsorbed properly. That's why fructose will be excreted in urine. Some amount of fructose will be reabsorbed, but renal threshold is low for fructose. Okay, clear? So the only and mainly catching point is, not only, mainly catching point of the age of presentation. Age of presentation. Yes, fructose. Yes, yes, simply they don't ask any question. They don't want to remember any test. They want to remember you that weaning start at 6 months. Weaning start at 6 months. Weaning start at 6 months. 4 to 6, sometimes 4 months. So in up to weaning the patient would be normal. Up to weaning child would be normal. Typical question, typical symptom where patient informant will come, the attendant will come with the child, will say, Dr. Saab, the child was doing well till 4 months. When we started giving fruit juice, patient started with vomiting, with all these symptoms. Means, yes, in this question, if you say 3 weeks old, 3 weeks old patient is taking only lactose, so no fructose exposure, so it can't be these two, because fructose patient present after, usually after 6 months. 6 months. Even an essential fructosuria, mostly patient is asymptomatic. Clear? Please do reply. Did you get this? So no need to go in detail, just remember the concept, how they want you to remember the clinical thing. Yes, many times you need not to differentiate between galactosemia and, yes, hereditary fructose intolerance. The history itself will tell you, if child is 2 year, yes, 2 month, 2 month old, and yes, before weaning, then it can't be hereditary fructose intolerance. Clear? So this aldolase B convert glyceraldehyde and DHAP. Yes, you all know, I have shown you the diagram. Please give me answer of this question. Okay, we found that this fructose metabolism, normally fructose, whenever fructose increases in our blood, this is freely filtered via glomeruli, but in glomeruli renal tubule this fructose is not fully absorbed, so most of the fructose is excreted by urine. In galactose and glucose, renal tubule want to reabsorb it as much as possible. That's why that galactose increases in blood. That's why we say galactosemia. But in case of fructose, this fructose is not completely reabsorbed because renal threshold is low. So most of the fructose are excreted in urine. So whenever fructokinase is deficient, as fructose increases in blood, as fructose increases in blood, most of the fructose are excreted by urine, not absorbed, excreted by urine, not absorbed, excreted in urine, and patient remain asymptomatic. Yes, so that's why it is we say essential fructosuria. It is essential to keep, if fructose will be excreted in urine, patient would remain asymptomatic. Yes, essential fructosuria. If this hereditary fructose intolerance, this aldolase B is deficient, this fructose 1 phosphate will accumulate. The same concept of galactosemia was there. Yes, classical type. All the phosphate will be accumulated in the form of fructose 1 phosphate. All the phosphate will be accumulated in the form of fructose 1 phosphate. No phosphate for glycogen phosphorylase, so fasting hypoglycemia and hepatomegaly. Benedict test positive, but yes, age of presentation would be weaning, means when this patient will present after starting giving food, yes, juice, fruit juice. So typically that hereditary fructose intolerance patient present after weaning 6 months. Yes, so this patient 3 months old, it can't be hereditary fructose intolerance. Essential fructosuria, patient is asymptomatic, so answer is classical. Now in this question, routine examination of urine of asymptomatic patient showed positive reaction with Benedict test. If Benedict test is positive, anything may be possible, but can't sucrose. Sucrose is non-reducing sugar. Non-reducing sugar. So sucrose is non-reducing sugar. It can't be, yes, least likely to be present. Least likely to be present. Sucrose can't be present in urine. Yes, clear? Non-reducing sugar. I change this most likely. If I change most likely, then the answer is yes. Please do reply. If I say most likely, yes, if most likely, then answer would be fructose. Yes, most likely sugar which present asymptomatically. Yes, if most likely, then answer is B, and is least likely, the answer is C. Got the point?